welcome to the 6th Annual Mesothelioma Symposium. In the past, we've called this the lung-sparing mesothelioma symposium since we've been promoting lung-sparing surgery, but in the last few years that issue has kind of resolved itself, so we're now just a mesothelioma symposium. So we've been looking primarily at identifying new novel ideas for treatment, and we're going to, the first session we have today goes over just some of the clinical data, and then we're going to move on to that to some other clinical things later in the morning, but then mostly talk about interesting new concepts for treatment and hopefully get everybody excited. So I'm going to give the first talk, which is the background data for intraoperative adjuvant therapy, which I think is still an underutilized modality. I want to give everybody a warm welcome. This is a new facility at UCLA, so it's exciting to be one of the first meetings here. So we're very happy about have this facility close at hand. And we work with the David Geffen School of Medicine, Department of Postgraduate Education in the Dean's Office, as well as Pacific Heart, Lung, and Blood Institute and the Meso Center, who work together to put this on. So I want to thank everybody. And from everybody that's involved with this meeting, we want to welcome you to the Luskin Center, which is, like I said, just new, and we want to welcome you in whatever language that you speak. These aren't really all accurate because there have been some changes apparently. So please turn off your cell phones and any electronic devices that make noise. And if we hear anything during the symposium, you're going to have to stand up over here in the corner with a funny hat on your head. There is a pretest that we'd like you to fill out if you could, because we're trying to understand how well we're doing at educating people regarding the issues in mesothelioma. Breakfast is provided apparently outside in the nutrition lab. I'm not even sure where that is, but it's out there somewhere. And then lunch, this is wrong, it's an illumination room, but that's been changed to the Optimist room. So I'm not sure where that is either, but just we'll be able to direct you when lunch comes around. There's supposed to be a free meeting Wi-Fi, but I don't know that we actually have the right code yet. So when we find that out, we'll let you know. And anybody who's getting CMEs or CEUs from the meeting, please make sure that you fill out their evaluation forms by the end of the meeting so that we can make sure you get your credit. Okay, so I'm just going to, unless there are any questions, I'm just going to move ahead to my talk because it may be just a slight bit over 30 minutes, but I'm going to talk about options for intraoperative therapy. This is really hard for me to talk in this direction. And so I think this is a very underutilized modality because one of the interesting things about doing surgery is at the end of the operation, even though we haven't removed all the tumor is essentially exposed at least within a few millimeters. So there's opportunities to treat patients with local therapies that will avoid systemic toxicities in this situation. I have one disclosure, and that's an unpaid scientific advisor for the Pacific Heart, Lung, and Blood Institute. My overview is that I'm going to talk about adjuvant therapies, the type of adjuvant therapies that people use, current intraoperative therapies that have been used, supporting scientific evidence, which is actually very little, and then rational approaches, hopefully to kind of building a multimodality intraoperative adjuvant therapy for the future. So what is adjuvant therapy? It's an accessory treatment, basically, in addition to the primary treatment. It's supposed to be or enhance the effectiveness of the primary treatment. And the types of adjuvant therapies can be really anything. Radiation is a common one. Drug therapy, including cytotoxic chemotherapy, as well as targeted therapy biologics. Actually, surgery can be an adjuvant, particularly for things like germ cell tumor, when the primary treatment is chemotherapy, and then surgery is used at the end to remove any residual disease. And then there's other ones like ablation, embolization, and others. The timing is one of the things that distinguishes different types of adjuvant therapy. Classically, people have used, at least in surgery, have used postoperative adjuvant therapies in a lot of situations, and that gives one type of treatment, and that's been used a lot with mesothelioma with radiation and chemotherapy. There's induction or preoperative. Some people have used the word neoadjuvant, which is not really a very accurate word, but induction or preoperative therapy does also occur, but there's less, I think, rationale for using that in mesothelioma, at least at the current time, and then there's intraoperative, which I want to concentrate on. So the rationale for using intraoperative therapy is severalfold. First of all, mesothelioma is a diffuse disease, unfortunately, so it's not that we can do typically what we do for surgery, is take out the whole tumor en bloc with normal tissue around it. That's just not possible. So we're limited. We can't do an R0 resection, which I'll explain in a second. We can only do really an R1 resection, so we always leave residual cells. The other thing about surgery that some people don't appreciate quite so much is that surgery actually spreads the tumor. So if you do radical surgeries, you go into new planes and areas where the tumor wasn't before, then the tumor can get spread into the abdomen, get in the pericardial sac or something else where you actually open up spaces that the tumor hadn't been invaded before. So that's an important point. And you administer systemic therapies, usually systemically results in very low delivery of the agent to the actual pleural in the space and has a higher systemic toxicity because there's higher doses systemically. So intrapleural therapy it can reverse that and give high doses intrapleurally and lower doses systemically. Basically, the last one is that we are doing surgery. At least a lot of people are. Some people have kind of not stopped doing surgery, and so there is some controversy whether surgery actually provides a very big benefit. But I think in the long term, we're going to have to use multimodality therapy with all kinds of different therapies in order to get better survival. So I think surgery is going to be one of these. We're using it. We expose the tumor bed, so we might as well take advantage of that. This is kind of the problem. This is a slice of an edge of a lung. The pink stuff or orange stuff is lung here, and the white stuff that goes along the edge is the mesothelioma. And this is just the outside of the lung. So this is the problem, is that it covers everything, and the back of this obviously touches all the other things, the mediastinum, the diaphragm, and the chest wall. So getting this off with any kind of meaningful margin is not possible. So you always have this issue where your margins are right at the resection. So in terms of the margins, so marginal resection, which just leaves in microscopic disease that can be invisible to the normal human eye, is a R1 resection. That's typically what we shoot for. I don't think it's highly improbable and possibly impossible to actually get an R0 resection in almost any patient, although I'm sure there's an exception somewhere. And then incomplete resections happen unfortunately frequently, and that's something we try to avoid. So at the end, this is the inside of the chest. These are the left chest and the right chest. You can see all the different places. I put dots for all these different places where tumors have recurred, and it's just all the microscopic cells that are left in a very huge area that we're trying to treat. This is what really kind of gives us some encouragement in terms of doing this. This is Harvey Pass's data when he looked at doing surgery, and he had two groups. He reduced the residual tumor down to a microscopic or less than 5 millimeter amount, and he compared that survival and outcomes with patients who had a lot more tumor left over. And so the tumor that had a lot of tumor left over, the patients had this survival, and the ones that had less tumor left over after surgery had this survival. So this is not a randomized trial, but it does suggest that the more tumor you can reduce at the time of surgery, the more likely the patient's going to live longer term. So the current therapies that people have used intraoperatively are chemotherapy, and then there's hyperthermic or heated chemotherapy, radiation therapy, photodynamic therapy, and then there's a few other ones that I'll talk about at the end. Intraoperative chemotherapy has really caught a lot of people's attention because chemotherapy is used anyway. So because of the potential options of giving higher dose intrapleurally, it's been looked at in a number of institutions. There's an increased dose directly to the tumor bed, theoretically, and there's possibly a decreased systemic toxicity, although I will show some data that maybe kind of not kind of challenge that kind of concept. The disadvantages, of course, are that when you do surgery and you add things that are toxic to it, the two together can be more toxic than patients can tolerate. And we'll talk about a little later about the chemotherapy. The concept of chemotherapy is multi-dose chemotherapy, which does a single dose intrapleurally, and then with no other treatment following up on that doesn't necessarily help and could potentially generate resistant clones. So some facts are that generally in chemotherapy and mesothelioma, there's low response rates of 15 to 40% at best. Normally, according to our protocols, we're recommending 4 to 6 cycles based on the data. No single dose is in there, so single dose chemotherapy just doesn't fall into that category. There are significant toxicities that I think most people know about, and that generally nowadays multiple drugs are needed, 2 or 3. Unfortunately, a lot of the data I'm going to show you shows single agents or irrelevant agents that are used. So one of the earlier chemotherapy trials that were done intrapleurally for mesothelioma was done by a lung cancer study group, and this was a small sub-trial that came out of it, and this was published by Valerie Ruch, and they looked at 12 patients that had intrapleural cisplatin and mitomycin. Obviously, mitomycin is not really what we use anymore, but We can look at the cisplatin, and then what they did is they looked at the drug levels, both in the pleura and in the plasma, and looked at them from 1 hour on. In this trial, I'll talk about in a minute the other clinical part of this, but what basically they found was that the drug levels in the plasma increased very rapidly within 1 hour, and they were basically systemic levels that you would normally get from an infusion peripherally anyway, into systemic infusion. So even though you're thinking you're going to prevent toxicity by keeping a lower plasma level, it actually was basically the same as giving an IV dose of the drug. And that, interestingly, the half-life of the drug in the pleura was relatively short compared to what you might think it was, and the half-life of the drug in the plasma was much longer since it was being loaded basically from the pleura for a long time. So there was a longer half-life and just as high a dose as intravenous administration. So that kind of questions whether there's usefulness. And it's partly maybe from the fact that if you do surgery, you take the pleura out, you have a big absorptive surface, so it can just be absorbing anything very quickly. So this is the clinical portion of this. So it's the same trial. It gave cisplatin and mitomycin. And they followed up later on with systemic chemotherapy 4 to 6 weeks later. There were 36 patients entered, but really only 28 got the pleural decortication and intrapleural chemotherapy, and 23 only received the postoperative chemotherapy. So there were a couple of patients that went into renal failure, one requiring dialysis. So the problem with absorption is obviously systemic toxicity. Not many people mention about ototoxicity, but I've seen a number of patients who've been treated with HIAC or intrapleural chemotherapy that I've seen postoperatively that have very poor hearing, and they have to live with basically very difficult hearing for the rest of their life, which is not a great thing either. Mortality was relatively low, the major morbidity was low, but the median survival was only about 17 months, which is not bad for mesothelioma in terms of treatment, but you can get the same kind of values from any kind of surgery, so the chemotherapy doesn't seem to add much to it. So there have been 4 other publications. I'm not going to go into all the detail because basically all of them used either cisplatin alone or cisplatin plus an irrelevant agent that doesn't apply nowadays, and in all of them they failed to really demonstrate any benefit to intrapleural chemotherapy. So since chemotherapy alone may not be that beneficial, let's heat it and help it get into the cells and kill more cells. So this kind of a concept that dates back to this paper from George Hahn. Actually, I worked in George Hahn's lab at Stanford, and I did some of these hyperthermic experiments, but I didn't do this one. This was just actually a validation of an assay, dancel lysine, to show that the dancel lysine assay could show differentiation between different survivals of fresh tumors taken out of people and then treated with hyperthermia. So there was like 5 different tumors that was treated, and they were treated for 45 degrees, which again is actually higher, way higher than what people use clinically, for up to 120 minutes, and they looked at the survival. And interesting, melanoma and cervical carcinoma had very poor response to heating, just heating alone, no chemotherapy. And then colon cancer was a little bit better, but actually one of the more sensitive, quote-unquote sensitive ones was mesothelioma. So out of this, people kind of got the impression that mesothelioma was a sensitive tumor to hyperthermia, which is actually not true, which I'll show in a minute. But out of that kind of concept, people started doing HIAC in the peritoneum, and then out of that came heated intrapleural chemotherapy instead of intraperitoneal therapy. And this is kind of, I'm going to skip to the end, where David Sugarbaker gave this presentation at the American Association of Thoracic Surgery in 2013 in San Francisco. And he stood up there and he said he basically had 2 different groups. One was patients that had gotten heated intrapleural chemotherapy, and one that didn't. So these are the 2 groups. The heated intrapleural chemotherapy was 72 patients, the other one was 31. And he went through all these slides showing tables saying they're all very similar except for in one thing. And the one thing was that patients who got heated chemotherapy didn't get any preoperative chemotherapy. So he said, wow, these patients didn't even get preoperative chemotherapy, so they did better. Their survival was better than the ones that got preoperative chemotherapy. So these guys must really be doing better. And I didn't understand that rationale really, but when you look at other trials that have been done looking at induction or preoperative chemotherapy, this is the typical one that David Sugarbaker showed from his regular group. It's 19 months. And there was a multi-institutional trial looking at preoperative induction chemotherapy, which I didn't understand at the time, and I kind of declined to participate because I didn't understand that if you don't have that great of a chemotherapy drugs, you shouldn't be treating people preoperatively because most of the patients will progress. And in fact, the median survival from that study was actually lower than what his normal survival was. So preoperative chemotherapy isn't necessarily a good thing, and that may account for the difference in the two curves, that they got preoperative chemotherapy, which is actually more of a poor prognostic sign. So I was kind of interested in this, so we looked at it in the lab. We went in vitro. We did a whole bunch of different experiments with different cell lines and different conditions, and this is kind of a complicated slide. I apologize for that, but it's hard to show this. This is treating 5 different cells, 6 different cell lines with both chemotherapy and heat. Across here is increasing heat in each of these groups. This is different cell lines. And then within this group, there's increasing doses of cisplatin, and this is heated to 41 degrees. And these are the doses of cisplatin. They're typically responsive. And if you look at all these things in general, there's slopes of the curves for all the hyperthermia. Basically, there's not very much effect at all of the hyperthermia. There is an effect of chemotherapy. There's no question about that. But the heated chemotherapy, basically the curve is more like this, so it's not very dramatic, and it certainly doesn't seem to help to heat the cells in terms of, and these are in monolayer cultures, so if it doesn't work in monolayer cultures, it's not going to work in 3D very well either. So one of the key concepts I also think about that's a problem with chemotherapy in the pleural space is that in multi-dose chemotherapy, what you have generally happens, you give lower dose or higher dose, and you reduce the cell counts with each dose, and you have to let the patient recover, their normal cells recover and everything, and you give them another dose. So sequentially, you treat them until you get to a very low level. The problem with a single dose intrapleurally is that you give a single dose, it may reduce. Even if it reduced a lot, there's time before you do the next dose because you're recovering from surgery, there's growth factors, there's all kinds of other issues in the pleural space. So this may very well come back up to normal again, and you didn't really get any benefit from doing the intrapleural chemotherapy. So the hyperthermic chemotherapy really depends on how high hyperthermic chemotherapy depends on how high the intrapleural drug levels are. But unfortunately, as we've seen, the drug levels are associated with high plasma levels as well as systemic toxicity. And when you're doing surgery already and you're having all kinds of issues with recovery, the kidneys are certainly at stake as well as other areas. We obviously need multi-drugs, and most of the trials so far that we've done intrapleural chemotherapy are all single agents, and just now people are starting to get into little two agents. But now we're kind of with the French trial looking at adding bevacizumab. We're now trying to get into multiple agents, even beyond 2. The problem is also the follow-on chemotherapy is often delayed 4 to 6 weeks at best, and often can be later than that. And one of the interesting issues that I worked on in the lab actually was one of my protocols was when you heat cells, cancer cells, to 43 degrees or less, the amount of energy it takes to kill them is much higher than if it's 43 above. And the reason for that is that at 43 and below, while you're heating them, they develop thermal tolerance. So you can be sitting there, and it happens pretty quickly. So you can be sitting in the operating room and heating the patient for an hour, and during that period of time, the cells are all just generating thermal tolerance, and they're not being killed. So if you're going to do it, you have to do it to 43 degrees or above. And unfortunately, when you do that with surgical patients, there's a relatively high risk of thromboembolic disease. So it's really hard to heat the chest to that level and to actually accomplish those kinds of heat levels. I thought one of the most interesting for intrapleural chemotherapy is a depot kind of approach where this is Walter Weider's data that he actually showed when he was here last year, but he showed this preclinical study. There's nothing in humans that I could find yet, but he was giving intracavitary cisplatin, and he gave it with just plain solution, and he also gave it with a fibrin material that binds the cisplatin and holds it there. And so he looked at the levels in the pleura and the chest wall, and basically found with this fibrin preparation that at 2 hours and even 5 days later, I think it's 5 days later, basically the concentration in the chest wall where the tumor supposedly is, that's residual, was 2 to 3 times higher than in the pleura. So it was concentrated, and it seems like if you can do that, then it might be a reasonable thing to do. So in summary, for chemotherapy, Intrapleural chemotherapy is, I think, a great idea, but people have tried it for decades. There's problems with single agents versus what we really need is multiple agents, and then there's a toxicity that's added from surgery and chemotherapy at the same time. Hyperthermia really has no data to support it. I take the exception with what David Sugarbaker showed. That's not a randomized trial, and unfortunately, it doesn't really prove anything. Toxicity is real. Like I said, I've seen personally a number of patients that were in those trials and came out and they couldn't hear and they had kidney failure for the rest of their relatively short life, which is not a great outcome. We certainly need rational combinations, and I'm going to go through at the end some more biologic therapies I think can be less toxic and be combined to actually have a successful and very useful adjuvant therapy. There's no compelling evidence that's just the same. All right, so I'm going to go really briefly over radiation therapy because intraoperative radiation therapy is obviously very unusual and it's been hard to do, but it has been done. The advantages are that you can target areas of residual tumor. If there's residual tumor down by the diaphragm, you can actually target a beam there or some other delivery device, and you can spare other normal tissues rather than radiating the whole hemithorax and potentially the other lung as well. It requires, if you're going to really do it in different ways, if you're going to do it with a machine, it requires a very large machine, which is very difficult to deal with because it hangs over the patient. One of the things it definitely does is it increases operative times by, on the average, almost any therapy by 2 hours. And having the chest open for 2 more hours, putting things in it and doing things like that, the sterility of the chest, it becomes a potential problem. So this is a old trial. This was done at Memorial Sloan Kettering, and they had some really interesting thoughts about how to do this. But basically, they looked at mesothelioma patients that were operated on, and they had mostly plectomy patients. They gave them intraoperative radiation, and they gave 3 different kinds, which is kind of hard to follow. And they also followed it with postoperative electron photon beams with APPA fields and lateral fields and with lung blocks. So that's old technology, but it actually didn't work that bad. Intraoperatively, there were 22 patients that got radiation, and mostly it's because at Memorial, if you're at Memorial, if there's a little bit of tumor left somewhere, they just put things all over it and radiate it like crazy. So if there was a localized area of residual tumor, they put in I-125 implanted seeds. When they've done this with lung cancer too, and sometimes people actually cough the seeds up later on because it erodes through, it doesn't heal, and causes problems. But that was only in 4 patients. There's iridium afterloading catheters where you put a catheter in there, and then, 3 or 4 days later, they come back and put iridium sources in there and radiate to 30 gray in 3 days. And they also put in radioactive phosphorus 5 to 7 days later. The problem with this is that after 5 to 7 days, the pleural space is kind of loculated off, so you're really not treating very much when you do that. When they did this, they thought it was really successful because they got an overall survival of 25 months, which was really good compared to their previous series of patients, which had an overall survival, median survival of 6 months. So they were kind of relatively enthusiastic about this. So Valerie Rush, when she came to Memorial, kind of followed up on this and said, well, I want to do the afterloading catheter thing. So she did that. In a total of 13 patients, did it both in EPP and pleurectomy, 7 to 6. The OR time was just by doing this was over 2.5 hours. So it was increased, just fiddling around with this. There was a lot of mortality, 15%, and some pretty horrendous complications, including esophageal perforations, tracheoesophageal fistulae, bronchopleural fistulae, and significant mediastinal bleeding postoperatively. So their conclusion of this paper was that this is too toxic, you can't do it and shouldn't do it. So that was abandoned. So there's one trial. This is actually from, it was reported on from UCLA. From UCSF. Sorry, Terry. This is our trial from UCSF as a phase 1/2 intraoperative electron beam combined with postoperative conformal radiation. This was done in actually 24 patients, I believe, got it done. And what happened is that we used this big electron beam device, and early on we did pleurectomies, and he took patients down to the radiation suite. Then we had to open them up again and do this big, huge electron beam machine, and we used different levels of blocks to kind of reduce the penetration of the beam and treated areas that we thought might be at risk. And so generally, on average, of like 3.3 sites were treated per patient, and then postoperatively, they received conformal radiation to their chest, again with AP and PA fields and lung blocks. And this was published a little while ago, but the median survival, disease-free survival is 1 year basically, and the overall survival is 18 months. So again, we're kind of in that same range where everybody's getting 18, 19, 17 months with any kind of surgery and any other kind of combinations of therapy. So this was very kind of cumbersome to do, add a lot of time to the operation, so it just wasn't something that many people were interested in. So intraoperative radiation has been feasible in limited trials, but it doesn't really have much in terms of benefit to offer. So one of the other areas that's kind of a type of radiation, but it's a little bit more different, is photodynamic therapy, and this has been looked at by a number of people. One of the benefits of photodynamic therapy is you give a sensitizer. So you give the patient a sensitizer several days ahead of time, or 24 to 72 hours ahead of time generally, and it goes in their tissues. It's eliminated by their normal tissues, and then it's concentrated in the tumor tissue. And when you shine light of a certain wavelength, it's usually laser light, then it activates, heats those tissues, kills it. Necrosis causes necrosis, then kills those cells, and it's used inside the airway in lung cancer by some centers a lot, but there's some problems with it too. You can have decreased systemic toxicity or decreased normal tissue toxicity because of this concentration thing, but there also is added toxicity of doing this during surgery. And it's again a single dose, so doing a single dose of anything often doesn't necessarily help that much. And there's also the skin sensitivity. Now, the photofrin, which is the original one that people use, people would have to cover up literally with hats and masks and things and gloves. Particularly in Southern California, it's hard to do for several months when you're trying to avoid sunlight, and so it limits their ability to go and do things. There's a new one that apparently is a little bit better that has a shorter concentration half-life, so that side effect goes away faster, and that may be more useful. This is a series of patients that were done, just to give you an idea, the kind of average is 2 milligrams per kilogram of photofrin was given. They were given 20 to 30 joules, and the problem is also this is a laser light. So laser lights, you know, is like this. And so it's very hard to take that and diffuse it over the entire pleural surface. So there's different ways to do that. People have used intralipid to try to shine it in there, kind of just glows. And some people have used these different diffusers with a round ball that kind of diffuses it in every direction. But again, there's different distances and different areas that can be shadowed. It's hard to control the dose. In this trial, there was 7.5% mortality, which is kind of big with, again, bronchopleural fissure and the empyemas, because it's hard to control where the energy is going. It included esophageal perforation, ruptured spleen, diaphragmatic hernia, so a lot of problems. They had some favorable prognostic factors, but again, the median overall survival is 15 months, which is no different than any other surgical trial. This is Harvey Pass's trial. You have to congratulate Harvey because he's done one of the only randomized surgical trials in the literature in mesothelioma. He did a randomized prospective trial with 48 patients. I think he did this when he was at the NIH, and he again decreased, or I hate the word debulked, but decreased the amount of residual tumor to less than 5 millimeters, and treated with photofrin preoperatively, and then treated with photodynamic therapy. And I actually scrubbed in on a couple of these cases when I was at the NIH, and they were horrendous too, because we had to go down to radiation. They had to do all this stuff to do that, pour a bunch of intralipid into the chest, and he had a number of complications like that. But he was very good because he basically showed there's no difference in local control, no difference in progression-free survival, no difference in overall survival. So basically, it doesn't work. However, despite that, Paul Bass did another trial, which basically didn't help. It showed that the morbidity, however, was a little bit less, so he was able to control that a little bit more, but the overall survival was only 10 months, so this one didn't work either. Not to give up, Joe Friedberg really has tried to resurrect this a little bit, and he's going about it in a very good way. He's being very scientific and trying to show what the doses is to different places and all that kind of stuff. So he's done this preliminary phase 1/2 trial with 28 patients, and he's used photofrin, and basically you have to kind of change the OR lights. You have to do all this manipulation, so it's a lot of difficult things to do when you're doing this. But he was, I think one of the things is that he's a really meticulous surgeon, so he takes out almost every part of the disease. So 97% of his patients had no visible disease left, which makes a difference. And then he used kind of the usual range of laser light, 630 nanometers, and actually kind of a high dose of 60 joules per centimeter squared. So that's actually higher than most other people. His mortality was very good, 2.6%, and his overall survival was high, 31.7%. So his stage of disease is actually pretty high at 3.4 too. So this is impressive, but I'm not sure if this is his surgical technique versus actual benefit from the photodynamic therapy. He actually got approval for a randomized trial, which I haven't heard whether he's in the middle of starting. He moved at this point from Pennsylvania to Maryland, so I think that kind of got slowed up a little bit, so I haven't heard about where that is, but I'm really looking forward to seeing the results of that trial, hopefully, to put to rest whether this actually works or not. So now I'm going to kind of move on to something a little more interesting, intraoperative biologic therapy. So there's a lot of things going on in every cancer, kind of basic at this point, with more biologic therapy, more than cytotoxic chemotherapy, because you can take advantage of the biology of the tumor and either kill it or control it with different means. So the advantages of intraoperative biologic therapy includes, again, wide exposure to the microenvironment. The tumor microenvironment is the last kind of defense of the tumor against most biologic therapies. It changes the environment to be more favorable to its growth, and so this allows you to kind of get in there and change the microenvironment. So maybe you can get treatments to work a little bit better, particularly immunotherapy, which is what we're interested in. And the problem is also that when you do surgery, this is kind of an issue. When you do surgery, you create a big injured area where the tumor is, and then you have growth factors that come in to help the body heal. Those are all normal, but in the presence of tumor, that actually may help accelerate the tumor growth in some patients. One of the things that is a problem again with single dose, even biologic therapy in the chest, is that it's a single dose. It goes away very quickly. But if you're able to use depot or potentially cellular therapies, where you put a cell in there that stays in there and does whatever it's supposed to do for a longer period of time, it really might have an advantage. Again, there's toxicities to worry about, single dose problem, and potential problems with wound healing that you have to deal with. So some of the therapies that have been kind of proposed is thermal therapy, which is kind of a biologic therapy. It's just heat or cold, which I'll talk about briefly. And then there's toxins. I include betadine in this, as people have talked about this. And then IL-4 toxin is something that we've helped develop. And then there's immunotherapies, a lot of different kinds, anti-angiogenic therapies, gene therapies, and stromal cell or other stem cell therapies. So all those things belong. We're going to have a lot of talks in this area, so I'm not going to really cover this very much because we're going to see what new things that people are going to talk about. But I'm going to concentrate a little bit on these and just kind of talk about their usefulness. This is actually what I call a thermal print, like a fingerprint, but these are different cell lines, and we did a bunch of tests to see what happened when you heated them from anywhere from 45 degrees down to normal temperature, 37 degrees, and then we cooled them down to ultimately down to 0, then minus 80. And each cell line had a different response to those different temperatures, and we did different time points as well. But basically, this is Chinese hamster ovary cells. These are the ones that we classically use in the hyperthermia lab, where they're very sensitive to higher heats, and they're killed very easily as a positive control. As you can see up to here, this is 45 degrees. Up here, it kills the cells reasonably well. This is about 1.5 log kills, so that's not bad. But the rest of the cells that are in here, and this includes A549, which is a lung cancer cell line, and the rest of them are mesothelioma cell lines. The mesothelioma cell lines aren't affected by heat almost at all. And so this is pretty high heat, and the kind of concept out of that first paper that mesothelioma is a heat-sensitive tumor is just not true. It just does not kill them very well. But on the other hand, you get down to here, and you can see it's kind of basically no effect of any kind of temperature change until you get to 0 degrees. You get 0 degrees, and then these two mesothelioma lines nosedive. They just dive. You freeze them for a relatively short period of time, only 5 minutes, either for 1, 2, or 3 sessions, and then basically is 4 log kills, which is really what you need with chemotherapy, is dropping in several logs in order to kind of control this. One of them had only a modest effect, but the other cell lines, interestingly, actually didn't have that much effect from freezing. So mesothelioma, if it's not necessarily a heat-sensitive line, but it seems to be a cold-sensitive line. So we've been using this actually clinically to our advantage. So one of the things is those were all monolayer cultures. So when there's monolayer cultures, it's easy to do anything to cells and show a big effect because they're all spread out. You get the treatment relatively uniformly. So we looked at tumor spheroids and tried to see if there was the same kind of effect with tumor spheroids or they were more resistant. This is the Chinese hamster ovary cells, which show that there was only basically a modest effect, 40% reduction, down to 40% of their cell numbers, even with 3 cycles of freezing. A549, again, kind of the same thing, just kind of modest reduction. And then the spheroids, this is the MSTO spheroids, mesothelioma spheroids, went down to relatively low numbers, but they weren't as low as or impressive as with the monolayers. So when you're using this treatment, we had to figure that it's going to be somewhat more difficult than in the quick 5-minute freeze for monolayers. Another therapy, I'll go back to that in a little while. Another therapy that people have talked about is betadine therapy. And surgeons love betadine because it's an antiseptic. We clean the skin with it. We throw it into the surgical field. We do everything with it. And when there's an infection, and so people have been throwing this into places where tumors are basically not well controlled for a long time. And I thought this is kind of crazy, and betadine is not going to do anything. So we actually went to the lab and said, okay, we're going to look at the cells. We're going to see what it does. And so we had the same cell lines, basically. And this is just one sample of a mesothelioma cell line to show you. But we started off at 0.1% solution, and then went up to 5% solution. And we also did the heat, too, because there's some issue about whether you heat and help this or not. So we did up to 45 degrees. Again, clinically, nobody really goes up more than about 41 to 42. So it kind of stops here. So what happens up here is relatively not clinically relevant. But anyway, at low, this is actually a perfect dose curve. You basically at low doses, not much happens. Then you start to get the higher doses at 1% and 2%. It starts to drop down. 4% gets down to here, where you get 5% betadine, and there's no survival of any cells. So for being, as good as it is, that betadine is a simple solution that you can put into the pleural space, very easy to do, and it does seem to kill at least monolayer mesothelioma cells, and that's consistent with different cell lines as well. So there's also 2 other in vitro studies that have been looked at, and basically they look at mechanism of killing. What basically betadine is doing is generating oxygen-free radicals, and is causing cell death by basically necrosis, which can be actually counteracted with superoxide dismutase. So it's interesting that that's the mechanism. We can look into that a little more, but the bottom line is that it actually kills cells. It kills, actually, if you look at different kinds of cells, it kills most cells. So it's just kind of a non-specific. It's not a specific thing for cancer or mesothelioma. It'll kill normal cell lines too, just to a variable degree. But as you can see, that the drop-off is pretty dramatic in the other data. So Louis Lang-Lesdunsky, who I've talked to about this in UK, treated 102 patients. He presented this just recently, I think at the ATS or the IMIG last year. I can't remember which one, but he did 102 patients, and he basically did pleurectomies, and including intraoperatively hyperthermic, so he heats to 41 degrees, hyperthermic pleural lavage for, I believe it's an hour, with a 10% solution. So I was kind of intrigued by that. I said, we have data that shows that should be pretty useful. And his data actually shows that he does very well. His surgical mortality is 0. He's obviously a very detailed and good surgeon. His complication rate is very low. And he was interesting. He showed that the overall median survival generally was 32 months. The whole paper just talks about the whole group of patients. It doesn't talk about any factors in terms of betadine. And the interesting thing is his hospital is right next to a shipyard, or very close to a shipyard. So when anybody gets a pleural effusion, they're right in his office like the next day. So his distribution of stages is really early. Most of his patients had N0 disease, and most of them were stage 1, 2, and some 3 and 4. So his patient survival with that early stage disease usually is better. So it's not clear that the betadine is actually doing anything in this 32 months. I actually talked to him and proposed that we get together a randomized trial, and he declined so far. So I'm not really sure. That would be one of the things that could be easily done. Now I just want to jump ahead to do some other biologic therapies. Raj Puri was a colleague of mine at the NIH when I was doing research there. Came to give a talk at San Francisco. I don't remember if Terry was there or not, but but at the time, he was very interested in IL-4 and IL-4 uses in cancer therapy. There really wasn't very many. So when he gave the talk, I wasn't really, really listening carefully. He's talking about IL-4 receptors that he found on breast cancer, lung cancer, all these different cell lines, which were between 271 and 3,800 binding sites per cell. And so he was trying to give this an IL-4 toxin, which Ira Paston had developed with him, to cells to kill cancer cells. And the reason this is potentially useful because most cells don't have IL-4 receptors, and there are some immune cells that do, but they only have less than 300 binding sites per cell. So this was something that could potentially be targeted. And then kind of towards the end, he mentioned, oh, by the way, we've tested other cell types, and mesothelial cells have greater than 10,000 binding sites. So that's when I perked up and I said, wow, that's kind of interesting. So we looked at this and used a chimeric protein, which was an IL-4 molecule that had been circularly permuted and is bound to a Pseudomonas exotoxin. And we tried to see if this would be helpful to control mesothelioma. And this just basically shows the cell lines that were cultured with this toxin, MSTO211. And it shows with increasing toxin in this direction, the survival goes down. And it also shows if you give excess IL-4, it's reversible, and that you can reverse the effect with excess IL-4, which binds to the receptor. We looked at our tumors, the first 13 that we had done after we heard about this, and they were all either 2 or 3 plus staining for IL-4 receptors. There was a lot of brown staining in the cells, but and nothing in the control. So this was very intriguing. We did a murine model to look at the survival of these patients, and this has been published a while ago, but this is Meso-1, which is one of our own cell lines in nude mice, and this is the survival, this is the growth curve of the tumors as they get bigger. And we gave low dose and high dose IL-4 Pseudomonas exotoxin in either, it was Monday, Wednesday, Friday injections directly into the tumor. And with low dose, even it controlled them much better than any of the controls. And with high dose, basically eliminated everyone except for one mouse that had a very small nodule. If you look at the survival, these are the controls. They very routinely die around 20 to 30 weeks. And then the low dose IL-4 PE actually had reasonable survival, and the high dose basically cured the mice, which was pretty exciting. Unfortunately, this is an NIH controlled molecule, and they've had some problems finding somebody good to license it to, so we've had some problems for further clinical development, but just recently now we've been able to hopefully get our hands on some GMP grade material that we're going to hopefully do a clinical trial in the very near future with that. So I'm not going to talk about the immunotherapy and all that stuff. We'll hear about that in a second, but I just want to talk to you about the concept of what potentially surgeons can do in the future, and that is if you have the diagnosis of mesothelioma, you can then look at potentially preoperative treatment. And the preoperative treatment that I've been interested in is potentially, we're talking about doing this cryoablation. Dr. Apton is here. He's going to talk about that in a minute, which we do very routinely. Cryoablation is the same thing as the cooling that we showed experimentally. You freeze it 3 times, and it basically creates a dead ball of tumor antigens. So you can create potentially even a vaccine out of that dead ball. You can give IL-2 priming to help prime the immune system. Then you can do your surgery after you prime the immune system. And then intraoperatively, you can do multimodality microenvironmental therapy to help promote this. And the things you can potentially do is throw in some betadine. At least this is what we can do currently. Use water. Part of that experiment I show is that betadine is diluted in water, and the water itself also, makes cells swell and kills them. You can give betadine in water for a while until it kills as many cells as possible. Then you can take a little cryo sprayer, which we're using, and you can then freeze the surface of the chest. And so cells, when they swell and then you freeze them, they explode. So you can kill cells that way. And then after you're doing that, you can put in potentially a depot preparation of an IL-4 immunotoxin to kill any residual cells. And by the way, the IL-4 toxin is really good because it is released by the cell unchanged when the cells die. So there's a bystander effect. It keeps going on and on and on as the toxin doesn't get metabolized. And then eventually you can use immunologic gene-modified mesenchymal stem cells, which is something that we'll hear more about later, which is the way you put genes in to modify the immune environment of the healing chest so that you actually stimulate immune cells to come in, find the residual tumors sitting around, and then kill them. So ultimately, then after that big treatment, then you can follow up with chemotherapy, additional immune upregulation or interferon and other vaccine boosts and that kind of thing. So basically, I think that intraoperative therapies have a lot of promise. I think they've been really underutilized. I think there are problems with working with chemotherapy and other things that have high toxicity, but biologic therapies, potentially if they're concentrated and focused in the pleural space and potentially are made longer term with depot preparations or cellular therapy, that they hold a lot of promise. And even simple things like thermal therapies, cryoablation intraoperatively, betadine, water, and all that kind of stuff can play a role as those things have very little toxicity. And we've been doing the betadine wash now for a number of probably about 2 years, and we've not really seen any complications. And one patient did, for some reason, it went into his pericardium as well. We don't usually open the pericardium when we're doing that, but it went into the pericardium. He got ST segment elevations all of a sudden, which lasted during the perfusion. Then we washed it out, and then they went away. So it was kind of, that was the only odd thing that happened with that. But basically, the therapies are pretty well tolerated. Okay, now this is, I think, kind of the feeling that I have. I don't know if anybody's seen The Matrix, because if they haven't seen The Matrix, you won't get this. But anyway, The Matrix is a movie about the future. Can we back it up again? And there's this guy who. Hold on. Can you back it up one slide? Stop it from working. There's this guy who learns that the Savior is now here. So this is his reaction when he learns that, hey, the good news is coming. So can you play that again now and turn up the sound?
It's a very exciting time. We got a lot to do. We got to get to it.
So it's a very exciting time. We got a lot to do, but let's get going. All right, that's it.